Welcome everyone to another exciting edition of NeuroConnect, our weekly live event dedicated to unraveling the wonders of neuroscience. Together with eminent experts in the field, we aim to support and empower both patients and caregivers as they navigate the challenges of living with neurological conditions. I'm Deepa Tatkare, your host for today, as we embark on an insightful discussion about migraines in children and teenagers. Migraine headaches, a neurological condition characterized by severe and often throbbing head pain, can affect individuals of all ages, including children and teenagers. Migraines are not just ordinary headaches, they are a complex interplay of genetic, environmental, and neurochemical factors that result in a range of symptoms beyond head pain. Understanding how migraines manifest in children and teens is crucial, as their symptoms can be unique and sometimes challenging to identify. Migraines in children and teenagers can exhibit distinctive characteristics compared to those in adults. While the classic symptom of intense head pain is present, younger individuals may struggle to articulate their discomfort accurately. Children might experience difficulty describing the pain's location or intensity, leading to a potential misinterpretation of their symptoms. Teens, while better able to communicate, might still have trouble conveying the extent of their suffering. Migraines in children and teens often manifest with a diverse range of symptoms beyond head pain. Alongside the severe headache, they might experience nausea, vomiting, sensitivity to light, that is photophobia, and sensitivity to sound, that is phonophobia. One unique feature of pediatric migraines is the occurrence of abdominal pain, known as abdominal migraines, which can be mistaken for gastrointestinal issues. Additionally, some children and teens may experience visual disturbances known as auras, which can manifest as flickering lights or zigzag patterns. Migraine headaches in children and teenagers can significantly impact their daily lives. The intense pain and accompanying symptoms can lead to missed school days, reduced participation in extracurricular activities, and disrupted social interactions. Moreover, young individuals experiencing migraines may find it challenging to concentrate on their studies and engage in normal routines, affecting their overall well being. Recognizing and diagnosing migraines in children and teens is essential for proper management and support. Parents, caregivers, and educators play a pivotal role in observing patterns of symptoms and advocating for medical evaluation. Keeping a headache diary can help track the frequency, duration, and potential triggers of migraine attacks, aiding healthcare providers in making accurate diagnosis. By understanding the unique nature of migraines in young individuals and providing them with the necessary support, we can help elevate the impact of these headaches on their lives. To drive this further and strengthen our understanding, today we are privileged to have Dr. Surendra Koshia, a distinguished senior consultant neurologist at Eternal Hospital, a JCI accredited hospital in Jaipur, Rajasthan. With a remarkable career spanning associations with C. Hospitals and Rukmini Birla Hospital, Jaipur, Dr. Koshia's expertise shines particularly in movement disorders, neuroinfections, critical care in neurology, neurorehabilitation, acute stroke, and epilepsy. His membership in the International League Against Epilepsy and the International
इसको
Parkinson and
बताना जरा
Movement
एक
Disorder Society underscores his commitment to advancing neurology and ensuring the highest level of patient care. Welcome, Dr. Koshia.
Yeah, good afternoon, everyone.
Good
Now we
afternoon.
are moving on the now we are moving on presentation about the brief description of about headache and migraine headache, especially in the children and adolescent and teenagers. As we know, headache is the most common complaint in children and adolescent. In routine OPD, we see every day in the 5 to 6% of the headache. Most of the patient were children, adolescent, and in classification headache can be primary or can be secondary or other reason of the headache due to the cranial or pain, facial pain, and other pain. In primary headache is the most common is the tension type headache, and other than tension type is the migraine, cluster headache, and in secondary headache due to the trauma, any vascular cause, any substance abuse, brain infection, any metabolic disturbance in body and facial and cervical pain, and some psychiatric problem. Headache disorder are the second leading cause of the disability in the worldwide in female and male. First is the back pain, and in if we know about the migraine frequently is beginning in the childhood and highest prevalence in the adolescent and early adulthood, and peak in late teen and early 20s. Present in different way with the age from childhood to adult in form of the duration, frequency, location of headache. And about 1 in the 10 children experience recurrent headache due to the migraine, which can significantly impair their school performance, quality of life, routine, curriculum activity, extracurriculum activity. Up to 18% patient of the pediatric emergency room due to the migraine-related headache. And migraine in children can manifest different than the headache like cyclic vomiting, cyclic pain, abdomen syndrome, recurrent vertigo, recurrent vomiting, and can be considered as a GI disorder. The burden of migraine is enormous. Morbidity is not limited to the attack of the headache, but in between the attack, 1/4 of the patient remain anxious, remain irritable, and avoid routine activity. If migraine headache not treated at acute onset of headache, then can convert in the chronic migraine. If patient is very poorly treated, then in the approximately in a 1 year, almost 6.8% patient can convert in the chronic migraine. Childhood headache rarely caused by the serious underlying disorder or underlying malignancy or underlying brain disorder. Infection is the most common cause of the secondary headache in the children. Migraine is primarily headache disorder is common recurrent disabling condition affecting about 18% of the women and 6% of men in the world. And migraine before the puberty or before the menarche more common in the boy, after the menarche more common in female. And migraine headache can induced by stress, fatigue, various food, alcohol, drug, smoking, weather changes, and intense odor. And children with migraine have genetic predisposing factor. If the parent had a headache history of migraine, then approximately 50% chance to have migrainous headache in children. But if both parents have headache, then approximately chances to 90% chances to have migrainous headache in their children. Mutation in the sodium channel, calcium channel, and sodium potassium ATPase channel can lead to the type of hemiplegic migraine, which is the very serious migraine. The diagnosis of the migraine headache is based mainly on the history with normal physical examination. In history, what are the associated symptoms with the headache, which is the location of the headache, and description of the pain, intensity, frequency, aggravating factor, and relieving factor of the pain, and relation of the event like the history of head trauma started with a new medication or new activity, hormonal changes, any stress, any weight gain. And if the patient had a headache, then we take around history with any change in the headache frequency or headache character. One patient can be have more than one type of headache. If the patient had history of headache, then can patient have 10 type headache also. In detail history, first we ask about the with patient that at present what is the most bothersome symptom for you. Tell me about the any change in the headache frequency, headache intensity over the time. tell me about the what is the more severe at that time, and tell me that about at how this headache is start and how it go, and if you any identify any stress, any trigger point for the headache. In description of the pain, like the location, severity, and quality of pain, duration in second, minutes, or hour or day, and how many days in the month you have headache, and what is the improving or what is the worsening factor for the headache, like rest, movement, dark or quiet room. In associate symptom, like you have any associate nausea, vomiting, light sensitivity, photosensitivity, tearing, congestion of the eye, conjunctival injection, dropping of the eyelid, any agitation, irritability, and any associate pre-symptom like visual changes, speech changes, other neurological symptom, fatigue, yawning, irritability, food craving, and dizziness before the starting of the headache. In headache history, we also know about the what is the goal of the treatment, whether the cure or whether the decrease the frequency or intensity, and whether the you have want to do activity with the headache. And associate comorbidity with the headache, like any mood disorder, history of obesity, disturbance in the sleep, in some form of the insomnia or apnea, any associate fibromyalgia, neck pain, neck dizziness, vertigo, IBS, associated with that any other comorbidity like diabetes, hypertension, thyroid illness, asthma, and allergy. As we know that the if we label the diagnosis of the migraine with normal physical examination. For normal physical examination, at least the no any focal deficit. It's mean no any weakness in extremities, no any visual symptom in form of the double vision, blurred vision, and normal fundus examination. Fundus examination is the dilatation of the pupil and see the fundus of the optic disc. Any inflammation of optic disc we call papilledema. If any patient of the headache had papilledema or any focal deficit, then it is a secondary headache, not primary headache or not migraine. And know about any tenderness in the neck or shoulder tightness, any trigger point, and also ask about the, any alarming sign. If the patient didn't give proper history, then we can miss the secondary headache. If the patient had extreme age of onset before the 6 or after the 50, then we think about the secondary headache. Any change in the personality, any positive family history, significant positive family history, any focal deficit, any fever, any altered sensorium, any history of seizure, then we think about the secondary headache. As we know, in the primary headache disorder can be divided in the migraine, tension type headache, trigeminal, autonomic cephalgia, and other primary headache. In short, migraine typically start in the adolescent and menarche, but cluster headache in 20 to 40, and intention type headache at onset at any age. And other in other history with the intensity moderate to severe, pulsatile in character, aggravated by the physical activity, and associate symptom with the nausea, vomiting, photophobia, phonophobia, in migraine headache. And most of the patient of the duration of the migraine headache 4 hours to 72 hours. Any associate, and now we came on the phases of the migraine. Migraine had four phases. First is the prodrome, second is the aura, then acute headache, and then post-drop. In prodrome state, patient can notice that he had started with the headache in the next 1 hour or next 2 3 hours, and if the patient notice the prodrome, then can patient identify the trigger, then he or she can avoid the trigger and can control the headache and can reduce the intensity and frequency of the headache. In prodromal phase, patient had difficulty in the concentration, irritability, depression, difficulty in thinking, reading and writing, trouble in flipping, excessive yawning, nausea, fatigue, sensitive to light and sound, excessive food craving, increased frequency of the urine, and muscle stiffness and muscle tight and muscle ache. And prodrome phase can be last from 3 hours to days, but in aura phase can last from 5 minutes to 60 minutes. Aura start and progress up to the 60 minutes and last up to the 60 minutes. In aura, maybe seeing the light, flashes of light, zigzag light, blind spot in your eye, tingling and numbness in extremities, ringing sensation in ear in form of the tinnitus, temporary vision loss, and change in the smell and taste sensation, and feeling the hungry. In patient Headache phase in migraine, headache lasts from 4 hours to 72 hours in adult, but in teenagers or in pediatric age group, headache can last from 2 hours to 72 hours. In post phase can last up to the 2 days after the subsiding of the headache. As in, we can see the first phase is the premonitory, second is the aura, third is the acute phase, fourth is the resolution, and fifth phase is the postdrum. And after postdrum, the if the patient had headache frequency in the 2 or 3 times in a week, then patient had interictal phase or pain-free phase. If for diagnosis of the for migraine headache, we have a criteria ICD 10 diagnostic criteria. At least 5 attack fulfilling the criteria from B to D. Attack, if untreated, last for from 4 hour to 72 hour. Two or more than two in the following: unilateral in location, pulsating in quality, moderate to severe headache, and aggravate or causing avoidance of the routine physical activity, and associated with the one of these: nausea and vomiting, photophobia and phonophobia. Feature of the migraine in children, as we say in the previous slide, the attack lasts from 2 to 72 hours, and headache in the adult is a unilateral in location. Most of the patient, but in pediatric age group, can be diffuse, maybe posterior in location, and photophobia, phenophobia, and less in the children. And then the most of the children had any behavior problem, change in behavior, irritability, pain abdomen, and any vertigo. Migraine with aura. Aura means patient had fully reversible symptom, which may be in form of the visual symptom, sensory symptom, speech and language disturbances, motor symptom in weakness, brainstem or dizziness, vertigo, double vision or blur vision, retinal, sudden onset, transient loss of vision. Migraine occur in the succession. Aura can last from 5 minutes to 10 minutes to 60 seconds. If unilateral, may be aphasia. In positive, scintillating pins and needle. In negative, blind spot. Type of migraine in the children. In children, maybe patient children or pediatric age group can migraine can present with the abdominal migraine. Abdominal migraine is characterized by the recurrent episode of abdominal pain in otherwise healthy child who is normal between the attack. And pain typically localized in the midline or poorly localized, dull, moderate to severe in intensity. Second form can present with the benign paroxysms and vertigo. Children complain recurrent episode of the vertigo in otherwise healthy children. Cyclic vomiting syndrome is defined as an idiopathic disorder characterized by the repeated, usually stereotypical episode. It means same type of episode in recurrent in form of the nausea and vomiting, which can last from hour to days. And in between the cyclic vomiting syndrome, patient remain abdominal pain free or vomiting free with variable length. In also can present with like the benign paroxysmal torticollis is characterized the first stage pain posting of the head or neck. Sudden posting of the head or neck can be turned either side and last up to the hours or days. For chronic migraine, if episodic, if headache lasting from the 15 days to per month, more than 15 days per month, at least 3 months, and at least 5 attack, 8 attack, classical of the migraine. In pathophysiology of the migraine, first activation of the trigenovascular system, which lead to the release of the many vasoactive peptides. Most common is the calcitonin gene-related peptide. Then these increase in the trigenovascular activity, lead to the neurogenic inflammation, and lead to the drop threshold for the pain. And these pain threshold lead to the increase, eventually activate the pain system in the brain, and also increase the sensory change in the sensory arousal C1 C2 dermatome, which lead to the neck pain, neck tightness. Here we can see the vulnerability. If the attack start with the prodrome or aura, then pain due to the release of the minimal activation of the trigenovascular system, which lead to the release of the vasoactive peptide, most common the CGRP. Most common is calcitonin. And other than the CGRP, other pathophysiological other substance which is serotonin and migraine, like 5-HT1 receptor, 5-HT1D, and 5-HT1F receptor activation also lead to the activation of the pain system in the brain. If it block the 5-HT1B, 1D, and 5-HT1F, then we can subside the pain. Now we move on the strategy of the migraine management. First is the lifestyle intervention. Second is the acute treatment, and third is the preemptive treatment. It means before the pain start, we identify the trigger and we limit the trigger. And in preventive treatment, if the patient had recurrent headache in the month or patient had chronic migraine, then require preventive treatment to decrease the frequency and intensity. And if all these fail, then we can use the rescue treatment. Goal of the acute treatment is the rapidly treat the acute attack, reduce the minimal recurrences, reduce the use of the additional rescue medication, restore the normal functioning activity, minimize the adverse effect of chronic treatment, cost effective, and reduce the subsequent resources used in form of the reduces the office visit or hospital visit, emergency visit, urgent care, and absence from the home or absence from the work. Medication for the acute treatment of the migraine level A evidence is the first is the triptan and ergotamine, and routine analgesic aspirin, ibuprofen, naproxen, and diclofenac, and acetaminophen. And in combination, when you use with the simple analgesic or triptans or and routine analgesic, can use in the combination ditans or G-pens. Level B evidence antiemetic, ergot alkaloids. Other than routine analgesic, the ketoprofen or ketorolac, and in nutricals, magnesium, thiamine, riboflavin. Now came on the G-pens. Most common use the G-pens in the ubrogepant and rimagepant. Ubrogepant and rimagepant reduce the frequency of the absence of the most bothersome symptom at the 2 hour in the approximately 37 or 38%. Then the placebo, and in rimagepant also reduce the most bothersome symptom in form of the most bothersome symptom, maybe the nausea, vomiting, and photophobia, almost 37%. Then the placebo is the 25.2%. Safety and tolerability of the gepants. Ubrogepant less than 5% patient cause nausea, somnolence, dizziness, and dry mouth. But in the rimagepant, nausea in the only in the 0.7 to 2% or placebo. And move on the ditans. Most commonly use the lasmodietans. Lasmodietans also reduce the most bothersome symptom and control the acute headache in comparison to placebo in almost 35% of the patient. Then the placebo is 18.3% patient. But most common side effect with the ditans is the dizziness, paresthesia, and somnolence. And if the patient using the ditans, then he or she should avoid driving or operate machinery at least 8 hours due to the somnolence and dizziness. And which patients should be prescribed the G-pens or dietans other than the routine analgesic? Because G-pens and dietans are the expensive medication, and these are the potential for the substance abuse. G-pens and dietans should be used only in the patient of the contraindication of the triptans, lack of the adequate response or lack of the tolerability greater than 2 oral triptans, and patient preference. Now move on the neuromodulation or newer therapy in the migraine. Like FDA cleared the neuromodulation or non-medication or non-pharmacological treatment. In neuromodulation, we use the devices which can reduce the frequency, reduce the intensity of the migraine, and reduce the emergency visit of the patient without the drug. Most commonly used neuromodulation for the migraine is the supraorbital transcutaneous nerve stimulation. Second is the non-invasive vagal nerve stimulation, which can be used bilaterally, and remote electrical neuromodulation or RAN application at the arm up to the 45 minutes during the attack, and it's reduce the frequency, reduce the intensity, and most bothersome symptom of the migraine in 1 hour. Neuromodulation should be used if the patient failed on two triptans, contraindication of the standard therapy, overuse, and and abuse potential with the standard therapy. And patient wants non-drug treatment. Then neuromodulation should be used in the patient of the migraine. Most commonly is the first is the acute treatment is the where is the rain. Second is the Kafli, and third is the Kafli. And these are the devices which can be used for the. Yeah, this is the vagus nerve stimulation. This is the vagus nerve stimulation by the peripheral stimulation. Peripheral stimulation is reduce the intensity and frequency of the head. Now we move on the when to offer the preventive therapy for the acute headache or migraine patient. If the patient headache frequency interfere with the patient daily routine activity despite the acute treatment, attack frequency greater than the one migraine headache day per week, patient had contraindication to use the acute treatment, failure to respond the acute treatment, and patient overuse the acute treatment, and patient had potential for the medication overuse headache. Medication overuse headache is defined as greater than 10 day per month use of the irrigated triptans, opioid or combination analgesic is defined as overuse headache. If the patient use opioid analgesic acetaminophen or brufen or then defined as the medication overuse headache. If the patient had potential of the more medication overuse headache, then he or she should prescribe or should offer for the preventive treatment. And patient preference for the preventive treatment. Severity, improve the responsiveness, reduce overall cost of the treatment, enable patient to self-manage or enhance sense of the personal control of the acute headache treatment, improve healthy quality of life patient, reduce headache-related distress and psychological symptom or depressive symptom or anxiety associated with the recurrent headache. Principle for the preventive treatment: start with the low dose and increase slowly. Need adequate trial almost 3 months, minimum 2 to 3 months. First, one drug should be tried for the preventive treatment before adding the second drug. Avoid drug overuse and interfering drugs. Evaluate the therapy by adequate history, whether he or she is not taking the proper treatment, proper dose, proper avoiding of the trigger, and proper sleep. Except Botox and CGRP monoclonal antibodies should be started with a low dose and increase slowly. Botox and CGRP should be used in the full dose at first day. In preventive therapy like the anti-epileptics, beta blocker, ACR, ARB, and AC inhibitors, and CGRP related monoclonal antibody, which more common is most are the arenumab, eptinezumab, fermanezumab, and galcanezumab. And level B evidence with the amitriptyline, venlafaxine, and other beta blocker. And other than level B is level C and level U drugs are the AC inhibitor, antihistaminic, and gabapentin and verapamil or CCBs. In monoclonal anti, four injectable monoclonal receptor, arenumab, fermanezumab, galcanezumab. Now move on the lifestyle modification for the treatment of the acute headache or for the preventive therapy of the recurrent headache. First, identify the trigger, avoid the trigger from the diet, and do careful. Don't ever eliminate over, because if you eliminate over, efficiency. Took regular sleep at least 6 to 8 hours per day, and sleep hygiene, sleep duration, and sleep timing should be remain same. If patient had insomnia or any sleep related problem, then it should be adequately treated with sleep hygiene. And if not sleep hygiene, then if required, then with drug. Regular or moderate exercise, adequate hydration, and then relaxation and meditation. Biofeedback and cognitive behavior therapy had good role and good evidence for treatment of the chronic migraine. And also, we should know or identify which is the best for the patient, and patient adherent to the best for him or her. For improve the adherence, first we organize the study, provide the monitoring, cell monitoring in form of the headache diary, and possible at least possible reduce the number of the drug, number of the dose. If the patient need one or two drug only once daily, then patient remain adherent to the treatment. And patient should be always adequately educate about the trigger, about the avoidance, about the sleep, about the exercise, and about the headache diary. And if patient require, then the cognitive behavior therapy. And then for the support or for the acute headache, patient should be adequately informed by the staff. And we also educate the patient, and we also respect the patient decision for the treatment of the acute headache, in which can share decision mechanism, a process wherein the healthcare provider and patient work together to make a healthcare decision that is the best for the patient. Patient should be engaged and in the process, and all should be evidence-based information, knowledge and experience with the patient. Patient value and patient preference should be weighed. First is the in shared decision making. The first step is the patient participation. Second is the help your patient explore and compare the treatment available option and which is the best for the patient. Assess the patient value and preference, which is patient ready, and which treatment patient can took in long terms. Reach the decision with the patient. That means the patient is ready now. It's the treatment is the best, and he or she should take proper treatment and should follow and should adhere to the this treatment. And after the patient started the treatment, then we need to the evaluate the patient decision in form of the patient taking the proper medicine or not, or patient headache frequency or intensity decreasing or not. In seek in for evaluation of the patient, general purpose is that the patient or clinician can support patient decision so that the treatment has the best impact possible on the patient health outcome. Evaluate the patient decision also help in identify education and other support that patient need to achieve the treatment goal. Reinforce the importance of the treatment adherence and impact on the headache outcome. And we also provide the written action plan in the for future if the patient had recurrent headache. And support might include in the multidisciplinary care such as psychological support, treatment of the comorbidity, adherence support, communication between the headache specialist and the primary care physician as well as other member of the team, arrange the follow-up for the appropriate time for the next treatment plan and treatment need and patient support, and continue the providing the support and nurturing the hope of the critical role for the clinician. And for the future, if the patient had headache, then he or she can contact a nearby facility with the for the acute treatment or for the preventive treatment. Thank you.
Thank you, Doctor, for that insightful presentation, shedding light on the complexities of migraines. Now, let's open the floor to questions from our audience. Um,
Yeah.
the first question from audience is, can you please elaborate on the relationship between hormonal changes during puberty and migraines in teenagers?
Before the puberty and before the menarche, boys had the more frequency of the headache. After the menarche or after the puberty, females had risk of the more than the male because the hormonal changes in the progesterone and estrogen lead to the increase the frequency and intensity of the headache. And as also at the menses, some patient had menstrual migraine in which they started the headache before the menses period, before the 3 days and last up to the 3 to 4 days, which is also called the menstrual migraine. And menstrual migraine only required the analgesic at the time of the headache, not required the prophylactic treatment for the long term.
Okay, thank you for sharing those details. The other question that we have from audience is, are there any red flags that parents should watch out for to differentiate migraines from other types of headaches?
If the patient had children or teenagers had the change in the behavior, change in the personality, any focal neurological deficit in form of the decrease the movement of the any extremities, any asymmetrical movement of the upper limb, lower limb, any change in the vision, persistent change in the vision, double vision, blur vision, any asymmetrical movement of the eye, or any persistent ringing sensation in the ear, then he or she should evaluate for the secondary headache. And if any patient had history of other illness like the hemophilia, like any other drugs for the immunosuppression for the juvenile rheumatoid arthritis, type 1 diabetes patient can have secondary headache, any history of fever, any history of ear discharges, then patient can have secondary headache due to the brain infection. Patient can present it with the headache, but due to the risk of infection in immunocompromised patient or any other chronic illnesses, patient can present with the secondary headache.
Okay, thank you. Thank you for those details. The last one that we have is how can actually parents and schools create an supportive environment for children who are actually experiencing the migraines?
First, for the school and parents, first they identify that the children had migraine called with the acyphalic headache, or like we discussed with the abdominal migraine, paroxysmal vertigo, neck torticollis, cyclic vomiting syndrome. In below the 12 month of age, some child can present only with the complaint of the recurrent head banging. Some child with the infant colic, recurrent abdominal colic, presented with the migraine. But if the patient had only recurrent abdominal colic, recurrent change in behavior, episodic change in the head banging, then the head banging symptom of the migraine, then he or she does not require regular treatment, only required symptom of the migraine.
Thank you, doctor, for addressing these questions and providing valuable information
Evaluation for the
on different
migraine,
types of migraines.
and
Yeah.
then type of the food, only change in the routine sleeping time, any stressor, and can maintain a headache diary in form of the to identify the trigger and to eliminate the best possible of the trigger. If the we avoid or we eliminate the trigger, then the risk reduce the intensity and frequency of the headache, and he or she does not require regular treatment or chronic treatment, only required acute treatment. If the patient had headache in the once or twice in a month, then not required regular treatment, only required once or twice.
Okay. Thank you. Thank you for sharing these details. I wish we could continue this conversation. We appreciate your contribution and your valuable insights. We hope to have you with us again in the future as we continue to raise awareness about neurological disorders. Your continued support and participation would be invaluable in our collective efforts to make a difference. Thank you so much. As we conclude this enriching live event, we have gained crucial insights into migraines in children and teens. With a clear understanding of distinct symptoms and triggers, we are now primed to offer timely support, armed with comprehensive treatment approaches and the importance of fostering supportive surroundings. We are empowered to make a tangible difference in managing migraines. This event has undoubtedly equipped us to make informed decisions that enhance the well being of these individuals and create a positive difference. Thank you all for joining us today for this insightful discussion on migraine headaches in children and teens. If you found this discussion valuable, don't forget to tune in next week for another engaging topic, empowering our minds to conquer anxiety and embrace a life of courage and strength with Dr. Harbandana Sohani. Have a great day and take care. Thank you.